Here are some USMLE-style questions on conditions characterized by normal melanocyte number but decreased melanin production, such as albinism and vitiligo. Question 1. A 5-year-old boy is brought to the clinic by his parents due to concern about his light-colored skin and hair. The parents note that he often squints in bright sunlight and has difficulty tracking objects with his eyes. Physical examination reveals nystagmus, hypopigmented skin, and light blue irises. Which of the following best explains the underlying mechanism of this patient's condition? A. Defective migration of neural crest cells. B. Decreased tyrosinase activity. C. Autoimmune destruction of melanocytes. D. Accelerated keratinocyte turnover. E. Increased melanosome destruction. Answer B. Decreased tyrosinase activity. This patient has oculocutaneous albinism, which results from defective tyrosinase, an enzyme required for melanin synthesis. Melanocytes are present, but melanin production is impaired. Neural crest cell migration defects. Answer A. Cause pybaldism or Waardenburg syndrome. A 28-year-old woman presents with progressive loss of skin pigmentation on her hands and face. The affected areas appear well demarcated and completely depigmented. Wood's lamp examination enhances the contrast between normal and depigmented skin. Which of the following is the most likely pathophysiologic mechanism? A. Autoimmune destruction of melanocytes. B. Decreased melanin production with normal melanocyte number. C. Failure of neural crest cell migration. D. Defective endosomal trafficking. E. Increased degradation of melanin by lysosomes. Answer A. Autoimmune destruction of melanocytes. This patient has vitiligo, an autoimmune disease that leads to the loss of melanocytes in the affected skin. Unlike albinism, there is a loss of melanocytes, not just melanin production. Wood's lamp examination helps highlight affected areas. Question 3. A 17-year-old girl presents with diffuse hypopigmentation of the skin, light-colored hair, and blue-gray eyes. She has a history of frequent sunburns and decreased visual acuity. Genetic testing reveals a mutation affecting the conversion of tyrosine to DOPA. Which of the following best describes the likely histologic findings in her skin? A. Absent melanocytes in the epidermis. B. Normal melanocyte number with decreased melanin production. C. Increased melanosome degradation. D. Hyperproliferation of basal keratinocytes. E. Increased number of melanosomes within keratinocytes. Answer: normal melanocyte number with decreased melanin production. This is albinism caused by tyrosinase deficiency needed for melanin synthesis. Melanocyte number is normal, but melanin production is reduced. Patients have high sunburn risk and visual impairment, e.g. nystagmus, reduced acuity, photophobia. Question 4. A researcher is studying skin pigmentation and observes a group of keratinocytes containing fewer melanosomes than normal. However, histological analysis shows that the number of melanocytes in the basal layer of the epidermis is unchanged. Which of the following is the most likely diagnosis? A. Vitiligo. B. Albinism. C. Pulism. D. Chidiac-Hashi syndrome. E. Addison disease. Answer B. Albinism. Albinism is due to decreased melanin production with a normal number of melanocytes. Pybaldism, answer C, results from defective melanocyte migration, leading to patchy areas of depigmentation. Chidiac-Higashi syndrome, answer D, involves defective melanosome transport due to a lysosomal trafficking defect. Question 5. A 24-year-old woman presents with hyperpigmented skin in sun-exposed areas and reports a history of frequent hypoglycemic episodes, fatigue, and weight loss. Her serum sodium is low and potassium is high. Which of the following best explains the mechanism behind her skin changes? A. Decreased tyrosinase activity. B. Increased melanocyte proliferation. C. Autoimmune destruction of melanocytes. D. Increased POMC-derived ACTH, impaired melanosome transport. Answer D. Increased POMC-derived ACTH. This patient likely has primary adrenal insufficiency, Addison's disease, leading to elevated ACTH, which shares a precursor with melanocyte-stimulating hormone, MSH. Unlike albinism or vitiligo, this results in hyperpigmentation, not hypopigmentation. Would you like more questions or explanations?